Welcome to this week's episode of Ask Dr. Park, where tonight I'll answer your questions about upper airway resistance syndrome. So let's get started. Tonight I'm going to give a short description of what UARS is, or upper airway resistance syndrome, and then spend about 30 minutes to answer previously submitted questions. Then I'll open it up for live Q&A. If you have a question, please place it in the Q&A area and not the chat area. If you wish to ask your question by talking, just press the raise your hand button and I'll unmute you so that you can ask your question. I ask that you keep your questions short without getting into too much detail about your medical history. And just as a reminder, the information presented here tonight is for educational and informational purposes only and is not to be taken as medical advice. Please consult with your doctor, your medical doctor, before making any changes to your regimen. Now, to understand what UARS is, you have to define what sleep apnea is. The AHI, or the apnea-hypopnea index, is the total number of times you stop breathing for more than 10 seconds per hour. So it's not the total number of times, but per hour. That's why it's called an index. Apneas are complete obstructions, whereas hypopneas are partial obstructions, anywhere from 30 to 50% obstructed breathing. With hypopneas, you also have to have either your oxygen level dropping more than 3 to 4%, or your brain waves have to change to a lighter stage of sleep. I won't get into too much of the technical details because it's not that important. What is important, however, is to note that it's a 10-second threshold. There was a running joke that Dr. Guilleminault, who coined the term sleep apnea, chose 10 seconds because he had 10 fingers. I actually asked him why he chose 10 seconds. And his response was that 10 seconds is when you start to see negative physiologic changes. Essentially, this particular threshold has not changed since it was first set in the middle of the 1900s. So if you stop breathing 24 times an hour for 8 seconds each, then your AHI will be 0. Now, practically speaking, most people with UARS or sleep apnea will have a mixture of apneas, hypopneas, and sub 10-second events. And because UARS patients tend to be younger, thinner, and more likely to be women, about 2/3, sleep doctors don't take this too seriously. Even with sleep apnea, there are various degrees of sleep apnea with different treatment recommendations. So if you have mild sleep apnea, most sleep doctors will tell you to lose some weight and don't sleep on your back. If you don't have sleep apnea on a sleep test, then they'll most likely will blame your fatigue on other medical issues such as anemia or hypothyroidism. People with UARS are tired and exhausted, but not as sleepy with sleep apnea patients. Plus, you don't have to snore to have it. Besides chronic fatigue, other common symptoms of UARS include headaches, TMJ, anxiety, cold hands or feet, low blood pressure, digestive issues, or hypothyroidism. This condition was first described by Dr. Christian Guilleminault at Stanford University in 1993, where he studied healthy young thin men and women undergoing sleep studies using esophageal pressure catheters. And what he found was that with each successive breath in, the pressure in the chest cavity became lower and lower until the brain waves woke up and they began to breathe normally again. And none of these episodes fit the criteria for apneas or hypopneas. Now, for a more complete description on UARS, I'm going to place a link in the chat area to my interview with Dr. Guilleminault on UARS about 10 years ago. Sadly, he passed away about 2 years ago. Okay, now let's begin the Q&A. I'm going to answer the questions in the order in which they came in. All right. So let's just do this for about 20 or 30 minutes and then I'll go to the Q&A live area. And then if you want to raise your hand, I'll answer you so you can unmute you so you can ask your question live by speaking. The first question is from Blake. Back in the 1990s, when I first tested negative for apnea, I was surprised. I did my research and showed my doctor an NIH.gov paper on UARS. He fought to get me a dinosaur CPAP device, and as intolerable as it was at that time, I did notice some improvement in functioning. Fast forward 5 years ago, I went through another sleep study and tested positive for sleep apnea. Today, with a modern CPAP at a low ±2 AHI reading, I do function some better, but I only wake up refreshed for about 2 to 3 times a year. Could there be UAR events undetected by Philips StreamMaker? Well, Blake, it's great to hear that you're getting at least some improvement. Some is better than nothing, I guess. The thing about CPAP is that the algorithms that they use don't really address UARS. It only controls for your apnea. So it's the same thing as the sleep test. It has to be 10-second pauses or longer. If you stop breathing, let's say 10 times an hour for 8 to 9 seconds each, then it's not going to control for that. Whether it's due to the pressure issues, and even with the automatic machines, in theory, it should raise your pressure automatically. But again, the episodes have to be 10 seconds or longer. I'm sure there's a lot of other nuances with the algorithms, but that's a basic understanding of how I understand CPAP's work. Now, there are also lots of other variables that result in how well you sleep using a CPAP machine, such as how clear your nose is, your neck position, how much time you spend on your back, and other factors. And some people in your situation do better with different other CPAP or PAP devices, such as a BiPAP or even ASV, which is what Dr. Krakow recommended in our past podcast interview. And I'll place a link as well in the chat box. So put that right now. All right. Then others add on dental appliances, and a small number of people end up going for surgery. And this is maybe why, one of the reasons why the tongue nerve stimulation, the Inspire procedure, has relatively good success, is that it helps you to open up your airway with each breath that you take, unlike with a CPAP machine. ASV, what Dr. Krakow recommends on the other hand, does help you to breathe with each respiratory effort, just like a hospital respirator. All right, number 2. Let's see. Anne asks, what's the best diagnostic test for UARS? What sleep study parameters are most diagnostic? Number 2, does rhinomanometry help diagnostically? So, and unfortunately, there's no diagnostic test for UARS. It's actually made as a diagnosis of exclusion, meaning that if you don't have sleep apnea and you have symptoms, then you have UARS. And even if you have mild sleep apnea, at least you'd be given a sleep apnea diagnosis and everything will be covered by insurance. But the biggest problem, I think, is for many people is that if you don't have sleep apnea, nothing is covered by insurance. Now, the vast majority of your symptoms are probably going to be in the sub 10-second threshold limit. Now, when I was in practice, I made the diagnosis based on history, physical exam, and a normal sleep study. Oftentimes, you see lots of arousals in the sleep study as well, with lots of sleep fragmentation. And many of these patients with me ended up undergoing this drug-induced sleep endoscopy, which is a very useful exam, especially if you see something obvious, which you usually do. You can also do what's called esophageal manometry, what Dr. Guilleminault did, but that's hard to find in this country for a sleep doctor, to find a sleep doctor that does that, who does it regularly. And I'm sure they're out there, but the only one I know that does it on a regular basis is Dr. Gerald Simmons in Texas. And to answer your second question, rhinomanometry, it's actually more investigational and it's not that useful in clinical diagnosis, since most people with sleep apnea and UARS have nasal congestion. It's more useful as a clinical research tool to objectively measure improvements after some type of therapy, whether medical therapy or surgery. So Mary asks, are you familiar with WatchPat and sleep image home tests? These tests claim to detect UARS in patients. Which of these would be better at detecting subtle UARS cases? Are there any other home sleep tests that can be used? Thank you for the work you do. So Mary, these two devices are novel and unorthodox ways of measuring sleep quality. The WatchPat is unique in that it measures sympathetic tone changes on your finger. So every time you obstruct, even partially, it picks up these constrictions of your blood vessels. And it's also highly correlated with in-lab sleep studies, and the insurance companies do accept it as validated testing. Now, I'm not too familiar with sleep image, but from what I can see, it measures your heart rate changes and oxygen levels, perhaps movement too. There are variations of this type of testing called high-resolution pulse oximetry. And there's some good data showing that it's useful as a tool to measure objective changes after some form of treatment, but it's not used formally in the medical setting. It seems like it's targeting the consumer instead, like the Oura Ring. Personally, I prefer the watch pad since it's so sensitive and the RDI tends to be a lot higher and it's accepted by validated tests by insurance companies. Just to explain what an RDI is, an apnea plus hypopneas per hour is your AHI. And these are the apneas, which I described before, 10-second pauses, complete obstruction, hypopneas, partial obstruction, more than 10 seconds with brainwave arousals or oxygen dropping more than 3 to 4%. And then everything else, less than that 30 to 50% partial obstructed breathing. So let's say it's only 10 to 20% obstructed breathing, so what's called flow limitation, but you still have brainwave arousal, but no desaturation. So, and that has to be 10 seconds or longer. That's called a respiratory event related arousal. So more subtle partial obstruction, but still causing consequences, which is your brainwaves waking up. So if you add that to the apneas plus hypopnea, that's the respiratory disturbance index. And now that can be only tested on an in-lab sleep study because you have to measure brainwaves. But then there are other indirect measures such as the watch pad. Some people measure it using heart rate changes because that's gonna, when you wake up subconsciously, it's going to cause these physiologic changes. But like I said, the RDI is picked up much more sensitively by the watch pad. And oftentimes the AHI is low, like on an in-lab sleep study, but the RDI tends to be much higher. So that could qualify as a sleep apnea diagnosis based on the Medicare criteria. Damon asks, hello, Dr. Park. Thank you for doing Q&A on UARS. While the situation is more or less, surgically solvable with airway resistance in the head area, it's not clear what to do with collapse at the level of larynx or neck area. Is there a type of surgery to address that? Thank you for considering my question. I cannot find information on the internet regarding my options. So essentially, the surgical options for UARS are identical to that of sleep apnea. It's just that because you don't have sleep apnea, nothing is going to be covered by insurance. And these surgeries can be very expensive, like tens, even $20,000, $30,000, $50,000 for a simple surgery. And if it includes hospital stays, it's even more. So generally, surgeons are not going to offer any kind of invasive surgery unless you have a significant sleep apnea condition and you haven't responded to any conservative non-surgical options first. But in answering your question, in terms of the lower part of the throat, besides the soft palate, I think we've talked about that multiple times in the past, the palatoplasties, and a little bit lower down, you have the tonsils, if you have big tonsils. Below that, you have the tongue base. Because the jaws are small, the tongue takes up too much space. And then if you have chronic reflux, you may also have large lingual tonsils, which are at the base of the tongue. And then behind the lingual tonsils is the epiglottis that we see a lot falling back. So these are all areas that can obstruct either alone or in combination with all the other areas. So that area is called the hypopharynx, the lower part of the pharynx. And that's a lot more challenging because it's hard to see in the office. But with sleep endoscopy, it's a lot more easier to see what's going on. And so you have to kind of address the entire pathway, like I've always said, from tip of the nose all the way to the voice box to get good results. And that's one of the reasons why surgical options in general, targeting only one area, doesn't work that well. Okay, Tina asks, I have sleep apnea and use CPAP, but doesn't feel better. In the morning, lots of pressure in the head and ears and sinus and dizzy. How can I resolve this? And could it be UARS? And this is why not solved with CPAP. Lots of jaw and neck pain as well. So I kind of answered your question partially, Tina, in the previous question about how CPAP and APAP and all these devices only address apneas and hypopneas. Now, that has a lot of issues that go along with it too, because if you can't tolerate it because the pressure is too high or you get mouth leaks, all these technical issues using a CPAP machine. But let's say that CPAP addresses your AHI from, let's say, 50 down to 1, but you still feel terrible. And that happens quite often. What that probably means is that you're still having more subtle obstructions. And you'll see that on these sleep studies or the watch pad. You have lots of microarousals that the CPAP is causing. And that kind of goes along with this concept of the Heidelberg uncertainty principle from physics. If you intervene and do some kind of treatment, or even if you visualize with light, you're actually changing these circumstances. And so while these devices can help, it can also disturb your sleep too. Depends on how sensitive your nervous system is, and everyone has different thresholds for how much things bother them, whether it's strapped to the face or inside the mouth. So that's why a lot of people who can't tolerate CPAP have to go into other options. Actually, there's one exception to that rule, which is, I've talked about this in the past, where you have to fully optimize nasal breathing, whether medically or surgically. And that takes everyone to a totally different level. Not in everyone, but in a significant number of people, it makes the CPAP work much better. All right, Stephanie asks, we recently completed an at-home sleep study for a 5-year-old due to ongoing concerns about OSA, and the results came back consistent with mild OSA. What is the best way to go about determining what is causing his OSA? Sleep endoscopy, other imaging? He's been examined by 2 ENTs in the past who concluded that he did not appear to have enlarged tonsils and adenoids. Physical exam in the office only. So interestingly, this is a pediatric question. And Dr. Guilleminault actually presented similar kind of data on UARS in children just before he published his paper on adults. So there is lots of evidence on this happening in children too. And I think at one time he argued that it was happening on a more chronic basis in children because they have these long periods of hyperventilation as opposed to adults that wake up really quickly. So in answer to your question, Stephanie, so this is always an issue where you have a toddler or preschooler or school grader with very mild sleep apnea or no sleep apnea, very symptomatic. And it's clear that they're not breathing properly. They obstruct, they snore, they're restless in bed, they sleep on their stomach with the butt sticking up or the neck extended, and they don't do well in school. Or they're just very cranky and they wet their bed sometimes. So I'm assuming that if I were to look in your son's mouth, I'm sorry, it's not, it didn't, you don't say whether it's your son or daughter, but when the child's, in general, when I look in kids' mouths, typically you can see the smallish mouth with narrow arches, high arched palate. And typically you have all the risk factors of a modern Western face. So the risk factors I mentioned before is thumb sucking, pacifier use, bottle feeding, nasal congestion, your genes, what you get from your parents, soft diets. There's a long list of other things too, including various toxins in the environment. And that's a very long topic for another session. But anyway, in terms of your child, typically with imaging is not going to help because you imaging patients usually sitting up, awake, and nothing is obstructing when you're sitting up and awake. And the sleep study will probably show lots of fragmentation, which is considered with sleep apnea. Typically, it's going to be worse when you're on your back in general. So oftentimes what I'll offer is the sleep endoscopy or a drug-induced sleep endoscopy to see what's happening to the airway when they're sleeping under local sedation anesthesia. Sedation anesthesia with propofol or what's called Precedex, these 2 agents that we use. So, and that oftentimes will show something significant. Like for example, you can have small tonsils that can cave in completely. You can have an epiglottis flapping back frequently that won't show up as an apnea, or the tongue base can collapse, or you can have all 3. And so what can appear relatively normal when you're awake can be very different when you're sleeping. So the question is, even if you find this, what do you do? Taking out small tonsils probably isn't going to help because it's not the tonsils that are caving in, but the tissues around the tonsils that are caving in. And then with the epiglottis, that's another very controversial area. And I've spoken about doing epiglottic procedures in the past with good results, but it's not mainstream therapy right now. Many ENTs are very reluctant to do these operations, especially in older children. So a lot of kids in this area end up going to see dentists for palatal expansion. And there's a lot of evidence showing that regular traditional palatal expansion was equivalent to a tonsillectomy for kids with large tonsils. So I think that's a good choice to get a good choice to make, to see a dentist for some kind of expansion therapy, not just to treat it, but to prophylatically make things better long-term, to give your child a bigger mouth. Ultimately, that's what you need. And for the most part, these devices work pretty well in children. However, the problem with these appliances, these palatal expanders, and this applies to adults too that use these appliances, is that it does a great job of expanding your jaws, but not such a good job pushing it forward. And they do to a certain degree, but not to the degree that you need. And some people, expansion alone is enough. They're very happy, but the vast majority needs something more, either additional soft tissue surgeries or more further expansion forward. Rarely they go into some kind of jaw surgery or jaw procedure or surgical assisted palatal expansion. Okay, so for your child, Stephanie, I guess the next step is the sleep endoscopy, and that may be a little bit of a challenge. More and more ENTs are starting to do it, and typically pediatric ENTs generally, from my understanding, do a lot more than adults. But the handful of adult ENTs that do sleep endoscopy are going to be the Inspire surgeons, the one that do the tongue nerve pacemaker implant option, but that's for adults only. Karen asks, can your UARS be linked to diet gastro issues? Of course. In my book, I described a young woman in her 30s who had major UARS, classic UARS, thin, healthy looking, very mild sleep apnea, cold hands, cold feet, low blood pressure, irritable bowel syndrome, depression, headaches. She was a mess. And she couldn't tolerate CPAP. She couldn't tolerate the mouth guard. And she had asked about any kind of surgery, but I refused because back then we didn't offer surgery for young, healthy people who didn't have, who only had mild sleep apnea. And so she was begging me, and I had just read a paper about this new tongue-based suspension procedure, and it's nothing too difficult to do because it's within the realm of what we do in our field. So we did the procedure along with a higher suspension and palatoplasty, and 6 months later, her sleep apnea was gone completely. But what was most shocking was that every other one of her symptoms were gone: the cold hands, low blood pressure, headaches, depression, and also her irritable bowel syndrome. And if you look at the literature, there's tons of studies showing that poor sleep for any reason, sleep apnea, URS, affects digestion in general. And one of the basic concepts I talk about in my book, Sleep Interrupted, is that when you're under any form of chronic low-grade stress, and poor sleep does that, your body thinks it's under attack all the time. Your body's going to divert energy and blood flow to your core muscles and to your heart so you can run or fight. The last thing you want to do when you're running or fighting is to digest or have sex. But under chronic low-grade stress conditions, you're going to have chronic diversion of blood flow to these organs like the gut. So it just doesn't function properly. So food just sits there or just passes through really quickly, and this causes inflammation. And so sleep is critical for digestion, including not just how well it works, but also the healthy amounts of gut flora, the bacteria that are so important. And they've even shown that poor sleep or sleep deprivation alters the ratio of good bacteria to bad bacteria so that you gain more weight. So there's so many supportive studies showing that there's a strong link between gut health and sleep with UARS or sleep apnea. Okay, Amber, let's just get some water. Amber asks, can a rhinoplasty lead to UARS? That's a good question. Yes, it can sometimes. And I've seen this happen where, especially in the old days, the 1950s, there was a Dr. Goldman. He was a famous Fifth Avenue plastic surgeon in Manhattan. And everybody who was anybody went to him for his nose job. And it was a pretty classic upturned nose like this with a tiny pinched in nostrils, an upturned nose. And they looked great. And that was what was fashionable. But what we found was that like 5, 10, 20 years later, they were complaining of nasal congestion because the nostril had to be weakened up here so the nostrils cave in. So you get this pinched-in nostril right there. And so not that that happens anymore, and most surgeons are aware of this possibility, but still does happen. If you're narrowing the tip of the nose for any reason, if you don't support it again, it's going to cave in either immediately after surgery or many years later. And so that's why when you do any kind of rhinoplasty, cosmetic or functional surgery, you have to think about this, think about what's going to happen to the nostrils, even if you're open on the inside. Most people have a combination of all three. If you have a high arch palate, the septum sits on the roof of the mouth. And if the hard palate doesn't drop, the septum just buckles to one side as it grows. Also, the side walls of your nose are more narrow. And the nostrils are more, this is your septum, nostrils are more narrow, like instead of being wide open, it's more like this. So it tends to cave in a lot more. And so when you breathe in, it just caves in more. And then if you notice it's stuffy, you're going to open your mouth more. And when you open your mouth more, the tongue goes back more. So you stop breathing more. Then you suck out more stomach acids, causing more inflammation in your throat, and that also going into your nose as well. So this is this constant chronic vicious cycle going on: inflammation, obstruction, and poor sleep, interrupted sleep. So, well, if you have the rhinoplasty, then it's probably a good idea to see an ENT, maybe not just an ENT, but a ENT trained facial plastic surgeon, and he or she can help you with this. This is a pretty standard techniques of rhinoplasty to address these issues. And there's various ways of treating the nostrils. Next question. Maybe I'll do 2 more questions and then go to a live Q&A. Jesse asks, what are some of the state-of-the-art oral appliances used to treat UARS? Do you see, number 2, do you see clinical improvement in patients with UARS when they address underlying causes of chronic inflammation? Thanks a lot. So number 1, what are some of the state-of-the-art oral appliances used to treat UARS? Now, in the early days, and they still do, dentists use mandibular advancement devices quite often for storing and monitoring moderate sleep apnea. And you would hear these amazing results from people who not only had their snoring taken care of, but all their other symptoms went away. And obviously they were treating UARS under the radar without a formal sleep apnea diagnosis. And even if they didn't have sleep apnea, they would end up going to a dentist for a mandibular advancement device. And not only do they feel better and sleep better, but their anxiety, depression, and digestive issues, fatigue, and the headaches all went away. And then now you also have the other options. I call them the functional appliances, but there's different categories. Essentially what they do is they expand the jaws in 3 dimensions. They do a much better job spreading sideways, but to some degree moving forward. And some purport to move forward even more. But there's a lot of different variations of appliances out there. Unfortunately, it's hard to get a great idea of how well these appliances work because there's been no systematic meta-analysis of combining all the data, and there are no cross-comparison studies between these appliances. So it's hard to judge which one is better. But ultimately, it depends on the expertise and the skill of the dentist that does this. If it's a qualified, well-trained dentist, they can do a pretty good job. And I don't want to be biased. I think I've seen all these appliances work to some degree, and sometimes they don't work. But I think it's worth considering, especially if you have UARS. And you'll see a lot of different brand names out there. I'm not going to name any names right now, but there's lots of maybe 5 or 6 common popular appliances out there. And some of them have similar overlap in terms of their origins, and others are very different. And there are very different treatment philosophies as well by different dentists. And the second question, do you see any clinical improvement in patients with UARS when they address underlying causes of chronic inflammation? Well, absolutely. So some people, for example, I had this one doctor who had major UARS, and all he did was take some Claritin. So once his allergies was addressed, he had less nasal congestion, he stopped snoring, and he slept so much better. So with sleep breathing problems in UARS and sleep apnea, usually it's a multitude of different levels of conditions, whether it's anatomy, inflammation, sleep position, hormonal status, age, whatever it may be. But sometimes you just need a little help. Maybe if you're kind of at the threshold here and you're here, and you take some allergy medications, you go above that threshold, then you're going to sleep much better. But then if you're down here, the allergy medicine isn't going to work for you. So this is a very important concept in sleep apnea and UARS, this threshold concept where everyone has a different threshold level above which they feel much better. But it's a matter of how many steps or how many modes of therapy you need to do to get above that threshold. Unfortunately, it's hard to know. All right, so it's 8:31. So I'm going to actually go to the here. Okay. So if you want to ask a question live, just press the raise your hand button and I'll unmute you to ask a question. But I'm going to go to the Q&A area here. All right. So Paige asks, what are your thoughts on nasal specific technique? Could it be helpful for UA or sleep apnea? Paige, I'm sorry, but I don't know what that is. I know there are lots of different therapies or modalities, whether it's a breathing technique or treatment or whatever it is. It sounds like a breathing technique. Anything that improves your nasal breathing can only help. And that's the first priority for any of my patients who has either sleep apnea or UARS is to fully optimize nasal breathing, not just when you're breathing at night, but especially, so not just when you're breathing during the day, but especially at night, because you don't know how well you're breathing. In general, the nasal breathing gets worse when you lay down at night because of gravity. Everything fills up more with blood. And in people with sleep apnea or UARS, the nervous system doesn't work properly. So it can't regulate the blood flow properly. So you get more congested, especially on the side that's on the bottom part, the gravity dependent side. All right. Terry asks, I've been diagnosed with UARS. I've been crushingly exhausted for more than 10 years, and I can definitely tell it's beginning to affect me cognitively. I'm a 46-year-old father of 4. Wow, 4 kids. I've tried BiPAP, but burp, have tiny little air bubbles come up in my throat as I try to fall asleep. So I haven't been able to tolerate it. I also do myofascial exercises, but haven't done them consistently enough to help. So I treat the symptoms with antidepressants, etc. Do you have any suggestions for me? Well, it sounds like your BiPAP machine may be giving you what's called aerophagia, swallowing air. So it comes up as air, and it can be somewhat uncomfortable. So basically, in your situation, I would go through the standard troubleshooting steps with your BiPAP machine, fully optimize your nasal breathing to make sure that your mouth stays closed, and do anything possible to keep your mouth closed, because even if you open your mouth a little bit, the tongue goes back more and you stop breathing more often. And so then you can get a mouth leak. You'll wake up a lot more often too. Let me see here. So if you, with BiPAP, so you may be a candidate for what's called ASV. This is what Dr. Barry Krakow recommends. And he actually did a major study that was published in a very prestigious medical journal. And what he showed was that people with chronic insomnia, treatment-resistant chronic insomnia, the vast majority had sleep apnea or UARS, and we put them on ASV. The vast majority of insomnia went away, including sleep breathing problems. And that it's a little bit challenging to get because most sleep doctors won't give you an ASV machine, especially if you don't have sleep apnea. So you have to pay for it out of pocket. And not too many doctors are able to calibrate the ASV machine like what Dr. Krakow used to do. He used to be able to when he had a practice in New Mexico. But I think in your case, I would just go through the standard troubleshooting steps. I mean, I don't want to, well, I guess I can plug my book. I have a book called Totally CPAP on Amazon. And I go through all the different troubleshooting steps that I've seen work based on 20 years of treating CPAP patients. But there's also a really good resource online, many resources online, one of which is cpaptalk.com, which is it's an offshoot of cpap.com. It's very dedicated users there that are more than willing to help people in similar situations. And then if CPAP doesn't work, then you may have to go to other options like a mandibular advancement device or some kind of expansion option. Honestly, surgery is not going to be offered for you because you don't have sleep apnea. But if you have any nasal congestion, that may be an option if you want to take care of that more definitively. Typically, my protocol is if you do nasal surgery, that is mainly to improve your nasal breathing and not to cure the sleep apnea or UARS. Although you may feel better, objectively, it's been shown that it doesn't help sleep apnea that much. However, you will feel better subjectively. Number two, it also helps the CPAP work much better, or the mouth guard work much better when you can breathe much better through your nose. All right, next question. Terry asks, I've had 3 sleep studies and don't qualify for sleep apnea or hypopnea, but my arousal index is between 10 and 20. I've also tried the mandibular advancement device as well to no avail with it adjusted almost 100% in the range. Yeah, so you've gone to the next level and trying the mandibular advancement device, Terry. It's challenging because again, I'm not looking at you in person and I'm not able to examine you, but I would, if I were you, I would, well, if you're in my office, I would take a look with the camera to see just a general anatomic examination to see what's going on. In general, I'm willing to bet that you probably have a small mouth, high arched palate, recessed chin. You don't sleep on your back. And you have all the classic symptoms of UARS, such as fatigue or headaches and migraines, digestive issues, anxiety, those kind of things. One thing that I've started to see later in my career as I did more and more sleep endoscopies are 2 conditions that I describe in my blog. One is what's called expiratory palatal obstruction, where the soft palate, when you breathe out, just backs up like a flap, like a valve. So when you breathe into the nose and out, it goes like this. But then as you breathe out through your nose, it just does this, and you can't breathe out. So suddenly the air comes out through your mouth. So you go like that. And so if you're using CPAP, for example, it's not going to work because you get air come out through your mouth, you get a mouth leak, and then you keep waking up. That's more in the sleep apnea patients. Now, but with UARS, what I see is when you do what's called sleep endoscopy, what we see is the epiglottis flops back significantly in some people. And that's something that I'm seeing much more than what I would expect to see, which is not too unexpected because if the jaws are underdeveloped, it kind of pushes the tongue and the hyoid bone backwards, and the epiglottis, which sits on top of the hyoid behind the tongue, flops back easier. And so this can cause lots of microarousals that don't show up as apneas. Actually, we're actually writing up a manuscript right now, and we're going to submit it for publication. We looked at sleep endoscopy findings in people with UARS, so AHI less than 5, compared to people with severe sleep apnea, and also just between mild, and severe sleep apnea. What we found was that people with UARS had much higher incidence of epiglottic obstruction compared to people with sleep apnea. So I mean, for me, it's not surprising, but from a sleep medicine ENT standpoint, it is somewhat surprising. So to see if you have this, you have to find out a sleep surgeon, someone who does sleep endoscopy on a regular basis, who may, and it's hit or miss whether or not you're going to find a surgeon that's going to be comfortable doing epiglottic operations. But in general, people who do lots of sleep apnea procedures should be able to handle that. It's not a very complicated operation because we do it for other reasons, like for cancer. Now, Terry, that's the soft tissue procedures are one option, but the other option, and this is kind of way out there, but anatomically and clinically, it's ideal. It's jaw surgery. Some people need jaw surgery because the jaws are so small. So ideally, you should expand as much as possible, and then if that's not enough, just push forward with the jaw surgery. And I know that's a big step, but for some people, that's the only thing that may help. And also for many women, I don't know how old you are, but I'm sure a lot of women on this call in their 40s or 50s. That's also the period when your progesterone levels drop in the premenopausal years. And as progesterone drops, the tongue gets more relaxed. And so there's a common feature of menopause. Sleep quality goes down. Okay, Terry also says, I have a dream station BiPAP, which has recently been recalled. Actually, there are a couple of questions about the Respironics recall. It's very unfortunate that they happened, and I'm kind of disappointed that the companies and the company really hasn't stepped up and replaced these models. People are just left hanging with no CPAP, and so they're not treating their sleep apnea, which is terrible. So the patients have to really go out of their way to hound the sleep doctors and the equipment companies and insurance companies to get a replacement. And there's a lot of confusion as to what has to be done. But you didn't say whether or not the BiPAP is helping before you use it, then hopefully it is. And if it was helping, then try to get another one replaced. Okay, next question is, so again, if you wanted to ask a question live, just press the raise your hand button and I'll unmute you. Oh, 5% raised hands. Here we go. Let me just get some interaction here. How do I get the, here you go. All right, so I'm gonna allow Andrea, I'm gonna allow you to talk. Go ahead and ask a question. Andrea?
What do they do in the epiglottis surgery?
So the epiglottis, there's many different ways of addressing the epiglottis. The most conservative way is to scar the mucous membrane opposite the tongue base. And as it heals, it kind of retracts the epiglottis inwards. And that's been described in many papers, and I've done it for many years. And the problem is that it's inconsistent. Sometimes it works, sometimes it doesn't. It's not that predictable. So then I started going to more aggressive procedures, like in addition to the scarring procedure, I put a stitch in, and that technically it looks great after you're done. But then even with the stitch, because it's not meant to stay in for long, these are dissolvable sutures, it comes out prematurely sometimes, and other times it can dissolve, and then it kind of the epiglottis flops back again. And then I resorted to cutting it 50% and 80%. And I started doing this many years ago because there's a big sense of concern by surgeons about the risk of aspiration or pneumonia or coughing or swallowing problems. The theory is that the epiglottis protects the airway when you're swallowing. But there are many studies showing that that doesn't really happen. There's one study looking at people with stab wounds to the neck. They slice off the epiglottis, and also cancer patients where they cut off the epiglottis even more. And what they did was they all underwent swallow studies, and every one of those patients had no aspiration. What happens is that the tongue takes over to block the airway. Now, some people do have it temporarily, and in my series of patients, we did a review about 50 patients who had partial to total epiglotectomy, and no one had any permanent swallowing problems. Maybe 5 or 10% have it temporarily for a couple of days. And so there's different ways of handling this. Now, in children, in very young children and infants, pediatric ENTs do this all the time. But my sense is that there's more of a hands-off approach because it's taught that you eventually outgrow laryngomalacia. That's the epiglottic collapse. My feeling is that it doesn't really, it just morphs into something else. Yeah, because during those times you're not sleeping well, and that's going to retard growth and development and brain development. Did that answer your question, Andrea?
Yeah.
Okay, great.
Yes, thank you.
Sure. All right. David Nordman, Dr. Nordman.
Hello.
Hi.
Hi.
You're on. What's your question?
Okay, thank you. So my question is, as a clinician who's been sending patients for a few years to sleep studies, and there is a category of patients that will come back with from a full polysomnogram in a sleep center with zero or almost zero, let's say one, hypopneas, no apneas, and no evidence of UARS. And yet they do have what are called spontaneous arousals, supposedly within the norm, which is, suspiciously high. But, so they may add up to a few dozen spontaneous arousals through the night. And their symptoms are consistent with mild sleep apnea. So my question is, can we really say that it's not UARS, or broadly speaking, an obstructive issue? Like you began answering my question by mentioning the epiglottis possibility and the sleep endoscopy as a way of testing it and diagnosing it. But I guess I'm curious about, and maybe if you have a kind of a top 5 list of a few other causes that could explain it and how you investigate those.
Sure. So when you have lots of arousals, there are other topics in sleep medicine that you have to think about. TMJ, bruxism grinding, is a very common thing that we see. Now, in the old days, we used to call that a parasomnia, like sleepwalking. But now there's more and more studies suggesting that grinding and bruxism is a consequence of obstructive breathing. So the theory is that when you start to obstruct, the brain picks up the fact that you're about to obstruct and just causes your jaws to clench so that you can wake up, so you can start breathing again. Mm-hmm. And there's one really good study showing that in people with sleep apnea with bruxism, they saw the muscles grinding and clenching after the brainwaves woke up, but after CPAP, it went away. They stopped grinding. And also the other condition to think about are limb movements, periodic limb movements that cause arousals too. And I don't want to, and that has less of a connection to sleep breathing problems, but there are some studies showing that may be related to sleep breathing problems too. So all these things that cause you to wake up and get disturbed when you're sleeping at night, if you're not breathing properly, it causes a whole myriad of different manifestations, whether it's just rolling over in bed or tossing and turning, waking up to go to the bathroom, or moaning and groaning. So going back to the patient example, that's a very common situation where you have maybe slightly above normal arousal index. So if I remember correctly, the normal arousal index is around 10. Because
is that reasonable though? Or I mean, is it just like a norm in the population, but actually abnormal? Because it sounds to me like it's ridiculously high.
It has to be in that range, because if you turn over in bed, your brainwaves wake up. Or if you go into from a deep stage of sleep to normal sleep, your brainwaves have arousal. So there's certain criteria for how to score an arousal too. But I wouldn't look at the arousal index by itself. You have to look at the clinical picture and what's going on, along with the anatomy and the history. Mm-hmm. So if the patient has a high arousal index, but the patient has no symptoms whatsoever, there's no point in treating that. But the patient is symptomatic, has a typical expected small anatomy, typical clinical history. And even if the sleep study shows relatively normal numbers, my general recommendation is to go ahead and diagnose it and treat that. And the sleep endoscopy is my most common go-to device. But as I've said in past webinars, the sleep studies are becoming less and less useful for me now, because what I'm finding is that it doesn't, even though I use it as a kind of a guide as to see what direction we go, if you look back, it doesn't really change what I do or recommend. The only barrier is the insurance issue. That's the biggest barrier, because if you don't have sleep apnea, nothing is covered by insurance. Now, one caveat is that with the epiglottis, that's a different diagnosis. That's called laryngomalacia. So if you have that diagnosis, that is covered by insurance. Does that help?
Yeah, in part. So bruxism, basically you would investigate for evidence of bruxism dentally and address, like with TMJ, at least correcting TMJ imbalance, potentially doing some expansion.
Exactly. So for many of these patients, they need to see a dentist for some kind of expansion option. Even the TMJ treatment requires some kind of expansion.
Right. Okay. And for periodic leg movements, I mean, what causes that in the first place?
Well, there's a long theory about something going on in the brainstem with lack of iron, for example, and neurotransmitter deficiencies. But more and more studies keep coming out showing there's a connection between sleep, breathing problems, and limb movements too. Now, there's another thing that you have to cross out, which is iron deficiency. So they've shown that people with low ferritin levels have higher degrees of limb movement disorders. So you want to get that up to about 50 to 70, much higher than what's considered normal.
Oh, so the ferritin should be above 50.
Right.
Oh, okay. That's good to know. Mm-hmm.
Okay.
Okay. And any other, so bruxism, periodic leg movements, epiglottis, any other things that come to mind?
Well, those are the three most common things that I see. I'm sure there are lots of other medical problems that I'm not addressing. Obviously, there's other, life situations like emotional, psychological stress, life transitions, a lot of other things that I'm not seeing from these patients because I'm not with them. So you have to, that's why you have to get, like, I'm sure you agree that you have to get the big picture, not just look at the one body part or area by itself.
Yeah, great. Thank you so much.
Sure. Okay. Una? Una, do you have a question?
Mary were okay.
Hi, can you hear me?
Yes, I can hear you, Una.
Oh, this is so exciting. I'm ringing from London.
Oh, welcome from London.
Thank you so much. I think I have sleep apnea or UARS. I'm a patient at the Eastman Dental Institute, which I was assured, is meant to be one of the top hospitals, but nobody has examined me or taken a history, which seems very poor to me. They're offering me a mandibular advancement device, so I will try it, but I feel this seems a very odd way to treat somebody. And my other point is the only thing because I've had to be my own doctor really, the one thing I've found that has helped me is a device called Face Former. And I'm wondering if you have, if you recommend any myofunctional therapy, if you found that's useful.
Can you describe what face former is? I'm not familiar with that term.
I can show you if you can put the camera on.
Okay.
It's a bit like can you see me?
Let me see.
Is my video off? I don't know how to get the video on. It looks a bit like a dummy. Basically, you put it in your mouth and you pull on it and it exercises the throat and mouth and swallowing.
Sure. It's just a mouth throat exercise device. So that's in the realm of myofunctional therapy. So there's different ways of doing that voluntarily or using a gadget or device. There's even a new device that uses electrical stimulation to do the same thing for your tongue. And they all have value. And this is based on the fact that, especially for myofunctional therapy, there's really good solid evidence out there. There's a systematic meta-analysis done many years ago by my colleague, Dr. Mac Camacho from Stanford. He found that he combined all the different studies out there on myofunctional therapy. And overall, for adults, there's a 50% drop in the overall AHI level. And for children, it was 60%.
Mm-hmm.
I use that as a complementary option. For some people, let's say with mild sleep apnea or snoring, that may be enough. But I think it's a good complementary option to do on top of whatever else you're doing. And especially if you're doing any kind of dental appliance therapy, you have to do that. You have to use your mouth and your tongue, your lips and your throat properly to promote proper jaw development. So in terms of your first question, I'm so sorry to hear that you're getting the poor service, but
I think I forgot to say they did watch Pat, but that's all they have done in terms of anything, to examine me.
That's fine, and it's kind of a shortcut test. And like I said, I like the watch Pat because it's very sensitive. And, they see patients with similar situations all the time, and I guess they're confident that this is what you have. And since you don't have sleep apnea, the dental mouth guard is the next step to go in their algorithm. So, hopefully, unfortunately, I mean, that sounds like you didn't get good service from your providers, but
I just find it amazing that a doctor would not examine or take a history of a patient. To me, I've never come across this, and it's a leading hospital.
Yeah, that's what's happening in the US too, unfortunately.
Yeah. Thank God we still have the NHS. Okay, thank you very much.
Pleasure. Good luck to you. All right. I think we have time for one more question. Okay, Mr. Noah. James Noah?
Yes.
Hi, Mr. Noah.
Hi, good to talk to you.
How are you doing?
Yeah, I'm good. Maybe a run-of-the-mill question. You know me pretty well, but I use a really well-made mandibular advancement device that doesn't give me any TMJ, and I also use CPAP. I have a pretty new machine. I think that I use them together, and I really haven't heard anybody else. I guess maybe years ago I heard of somebody that did that, but do you experience or having patients any issues of using both of those together?
Believe it or not, I hear that quite often.
Oh, I see.
Kind of successful. More often than not, what they'll do is they'll use a CPAP at home and use a mouth guard when they travel. But I've had a fair number of patients use it together, and if it works, they keep doing it.
Yeah. Well, my main issue is EDS, and it comes and goes, so definitely not perfect. So yeah.
Well, you're fortunate that you found something that works.
Yeah. Right. Okay.
But unfortunately, it's not
Right.
to the degree that you want, but it's better than
Yeah.
nothing.
I think it helps keep the mouth closed. So
Yeah. Well, absolutely. Yeah. That's the other thing. And certain mouth guards allow you to open your mouth, and others don't.
mhm.
What kind of,
Yeah, it would be tough to open it with this one, I think, once
Yeah.
it's in place. All right.
Right.
Thanks so much.
Okay. Great. Good luck.
Thank you.
All right. I think maybe one more question. Let me go down the list again. Christina asks, any helpful at-home wearables to self-monitor pulse ox, heart rate, HRV, or ring value? Would do insurance companies even consider that data in improving sleep disordered breathing, especially if PHD is not definitive? Unfortunately, the answer is no. All these consumer devices are not acceptable from an insurance standpoint. It has to be a validated, designated sleep study, whether in a sleep lab or these approved home sleep studies. I know that the high resolution pulse oximetry, heart rate variability options, they have pretty good data from, I know a lot of dentists use it, and it's pretty convincing data, but that's not on the list of acceptable treatment options. It has to be a sleep study. Fortunately, we have home sleep studies that are acceptable now, in addition to in-lab studies. I think the other device that you mentioned, I think they're good to kind of keep track of how you're feeling based on what intervention that you apply. So if, for example, if you can just get your baseline data using the Oura Ring, and then maybe you want to try breathe right strips or sleep on your side. So make some kind of a change to see if it makes any objective difference in addition to how you feel. But what I want to stress is that you kind of have to take all the data from these devices with a grain of salt. What's most important is how you feel. So yeah, let's see here. I think we're near the end of the hour. Why don't we finish up? So that's it for tonight's Ask Dr. Park webinar on upper airway resistance syndrome. If you found tonight's program helpful to you in any way, please forward this podcast to a friend or family member that may find it helpful. Also, please leave me a great review on iTunes. If I wasn't able to answer your question tonight, you're welcome to submit it on my website at thedrstephenpark.com address under the contact tab. This is Dr. Park wishing you that you breathe better and sleep better so that you can live better. Good night.